really it's not really a consultation by any means. So the implication of that is, if you would be taking any major decisions regarding your mental health or mental well-being, in terms of really making any decisions or deciding on major steps in terms of interventions, please do consult with your personal care provider. That could be your psychiatrist or your general practitioner or your family physician or any of your mental health workers or counselors. Also, that we are now recording this, we've now taken consent and we are recording this event. And this will then be available on our website, on the YouTube channel, which the Tripart Care runs. And all of the previous recordings that we've had, all of the previous events, if you subscribe or visit our YouTube channel, which is called Tripart Care, the same name, you'll be able to get all those details on there. Right. So for today, we are going to be talking about depression. We are going to look at the facts and the figures. We are going to look at the symptoms and how to identify this. And the reason is because many times there are people who are actually depressed in our communities. We are not even aware of it, and that can be a problem. Very interestingly, I attended a meeting, the first of the meetings in my local organization, where we came together face to face a week ago, and I had a very gripping story, one that stirred the hearts of everyone in the room. A colleague had actually talked about the fact that they had been having mental challenges, and they were working with professionals, and yet it looked like it hadn't been picked up. So it just tells us that we really need to be on the lookout. We really need to be each other's keepers, and we really need to be looking out for one another in order to be able to identify these things and to support one another through these processes. We are going to look at treatment of depression. Antidepressants are not the only things that are used. There are other things that are used in treating depression, and we're going to look at those. We're also going to look at how do you support somebody who is depressed. If you if somebody confides in you, for instance, or you are a leader in any way, maybe a faith organization leader, a church pastor, or you preside over an organization, or you are even a business leader, how do you support people in your organization who have a mental, particularly who are depressed? And then what's the role of faith in all this? Does faith have a role, and what does it make any sense? What does research say? And then I'm hoping that we would also be able to then take questions and answer. So I'm going to start off by showing us a video from the Royal College of Psychiatrists, which I think is really a brilliant way to start today. I'm just going to share my screen and show that video.
We all feel down sometimes. It can last for a week or so without affecting our lives too much. Sometimes there's a reason, sometimes not. But with depression, your feelings go on for weeks and months, and they do interfere with your life. Depression has many symptoms, and you're unlikely to feel them all. It can make you feel unhappy most of the time. You might struggle to cope, lose interest in life, and feel like you no longer really enjoy anything. Depression can also affect your self-confidence, making you feel hopeless and inadequate. You might find yourself avoiding social situations. It can also affect your sleep. You might find it hard to get to sleep and feel utterly tired all the time. At depression's worst, you may even think of suicide. Luckily, there are steps that you can take to lift yourself out of depression. It can be incredibly helpful to talk about your feelings with a close friend or family member. You may find you need to do this more than once as part of the healing process. If you know what's behind your depression, try tackling it. Write down your problems, then make a list of solutions and pick the best. Keep active. Get out of doors for some exercise, even if it's just a walk. If you don't feel up to it, try housework and day-to-day tasks. Keeping active will help you sleep. If sleep's a struggle, Relax by watching television or listening to music. It may help you to feel less anxious and help you get some sleep. Depression can ruin your appetite or cause you to overeat. Try to eat 3 times a day, making sure you get plenty of fresh fruit and vegetables. Don't drown your sorrows with drink. Alcohol actually makes depression worse. It's normal to feel depressed after a distressing event, but you can get stuck in a depressed mood that doesn't seem to lift. You need to seek help if your feelings are worse than usual and don't seem to get any better. If depression affects your work, interests, and feelings towards your friends and family, if you start to feel that life's not worth living, or that people would be better off without you, you need to talk to your GP. Depending on your situation, your doctor may suggest ways of helping yourself, talking treatments, or antidepressants. Talking treatments can help you to get things off your chest and tackle unhelpful thinking patterns. If your depression is severe or long-running, antidepressants can help you to feel and cope better. Whatever you decide, remember lots of people have had depression. You will eventually come out of it, perhaps even stronger and able to make important changes in your life. To find out more about depression, visit the Royal College of Psychiatrists website.
Right, good. So I'm going to stop sharing that and then go back onto my slides. Right, so I think that's a very good summary of really what it's about today in terms of what we are covering. That gives a very brief overview, but a very thorough and brief, a very succinct one as well of what depression is about and what are the things that one needs to look out for. So basically, what is depression? The first thing I want to make, the first point I want to make is that it is a medical condition. Depression is a medical condition, and it's important to realize that depression is actually a medical condition. And the reason I say that is when people experience depression, sometimes in our communities, we have people say, pull yourself together, you're not man enough, man up. Those type of things don't really help, because if somebody had a thyroid problem or they had diabetes, we're probably not going to tell them, get more thyroid, get more thyroxine, or fill up your tank with insulin for your diabetes. But when it comes to depression, many times there is a stigma associated. So it's very important to know that it's a medical condition, and it's one in which many times what's happening is that there is a chemical imbalance in the brain that is causing a state of morbid sadness. I call it state of morbid sadness because, like it's been said in that video, when somebody is sad after hearing bad news or something is not going right, it's usually a short-lived experience. One is usually able to get over that situation, and one is able to recover after a few days, or maybe after you've spoken to a friend or you've done something that you enjoy. Maybe you've just had a good night rest. But when it comes to depression, no matter what people do, they can't just seem to lift that burden. It's like there's a dark cast, or there's a dark cloud over that person. And the other thing that we do know about depression is that it negatively affects thinking, feeling, and behavior. So depression negatively affects thinking, feeling, and behavior, and it also impacts negatively on the ability to function. So people are not able to function in their work life. They're not able to function in their relationships. They're not able to function socially. They're not able to function in the community, and everything just becomes a chore and a burden. Sometimes people describe it as like going through a dark tunnel without any evidence of light at the end of the tunnel. Like I've said earlier, it's not a sign of being weak. It's not a sign of being morally weak. It's not a sign of being not being resilient, and it's not a sign of spiritual weakness. Because I also do know that sometimes people in the faith community, sometimes in church, for instance, people might think that the reason why somebody is like that is because they are not spiritually strong, or they are not doing something right. So it's important to bear that in mind. Now, what are the facts and figures that we know about depression? Depression affects about 5% of adults globally across the world. And that's a huge thing. So that means that's about 1 in 20 when you think about it, of the global population of adults. The WHO tells us that about 280 to maybe, in fact, some figures even go up to 350 million people worldwide are affected by depression. And in England, for instance, we know that 4 to 10% of the population experience depression in the course of their lifetime. So over the course of the lifetime, up to 10% of people in England would get a depressive illness. And what we also do know is that females are more affected than males. So it's also important to bear that in mind, that females are more affected than males, and that females are more affected than males. And we know that 75%, which is also another reason why we do these things, why we give this, why we've got the emotional well-being hub, that 75%, that's 3 out of 4 people in low-income and middle-income countries who suffer from depression, who have the illness, do not actually get treatments. Yet we know that there are evidence-based interventions that actually are proven to be effective when people have when people are unwell, when people have a depressive illness. But it's sad to say that up to that percentage of 3 out of 4 people do not actually get treatment. And even when you come even to more advanced nations of the world, the figures are not particularly more encouraging, which shows us that there are still a lot of people who are suffering in silence, who are not able to produce, who are not able to give the best into their community, into their lives, into their families, into their jobs, or into just the wider global community because of depression. And this is something that can be treated. We also do know, last month, suicide was what we considered. We also do know that about depression plays a role in 50% of suicides. That's also, so really, usually I say that if you want to, one of the ways, if people ask me, how do you contribute to preventing suicide in your community? One of the ways to learn is to learn about depression, learn about identifying depression in other people, or if it's in yourself, learn about depression to the point in which, because we do know that 50% of suicide and depression plays a role in 50% of suicides. We also do know that if somebody has an untreated depressive illness, they carry a 20% risk. That's 1 out of 5, because it's important to put that in context. 1 out of 5, 20% risk of suicide because of untreated depression. And in terms of huge costs, it's actually astronomical costs, because we are looking at about 7 billion euros as an annual cost. So that's important to emphasize that that's not it's actually an annual thing. So I can see that my screen looks like it's obscured a bit. I'm just going to stop sharing and share again. Please bear with me 1 minute. Let's see now. Okay. Is the screen better now? No. Okay. It looks like I'm doubly sharing my screen. Let's do that now. Is it better? Okay, good. Right. Okay. So so that's what we know about in terms of the facts and figures of depression. So what are the symptoms? Like I said, there are symptoms that actually give it away, and when you see that, you can almost tell that there is depression going on. One of them, it's low mood, and low mood is not just low mood. It's low mood that it cannot be shifted. So it's not just somebody getting sad over not getting a job application or hearing some bad news or maybe having stress at work. It's low mood that cannot be shifted. Some people talk about being in a dark tunnel. Some people talk about life losing its taste. Some people talk about things just they find that they wake up in the morning, their moods are okay. They feel very burdened in the morning. They feel very low in mood. As the day wears on, the mood improves, but come tomorrow, it's the same pattern. And when they wake up in the morning, it's like, oh God, it's another day, because the burden of facing another day is just so severe. That's the low mood. So it has a particular pattern usually. But also there's low energy in terms of people feeling that they're lacking in energy. There's loss of interest in all the pleasures of life. Life just becomes like a chore. Life just becomes like a burden, like somebody's just going through the motion just to keep going. Also, sleep disturbance, poor appetite, those are very classical things. And the other thing to remember is that there's also the distortion of thinking, in which there are feelings of guilt. People feel hopeless, worthless, they feel helpless, like they're never going to get out of this tunnel. Sometimes there's associated anxiety, feelings of guilt about being a burden on other people, low self-confidence. And at its worst, there could be thoughts of not wanting to be here, thoughts about wanting to die. And so it could then extend to actually not wanting to continue to live and wanting to take one's life. Also, we do know that sometimes the libido is affected in terms of there can be diminished interest in sexual activities. So what are the risk factors? The first thing to say is that the risk factors is not just one thing that contributes to depression. It's not just one single thing. It's usually a number of factors. And the way to see depression in terms of why does this person get depressed is to think about one predisposing. Predisposing is, what is it that actually puts the person first at risk? What is it? Maybe it's something innate, something within them, or maybe something in terms of the experiences they've had in their childhood, or maybe something in terms of their genes that puts them more at risk than the common population. But also, there's also the precipitating factor, something that tips the person over the edge. What is it that event or that? So it could be somebody, for instance, has a family history, the parents. Maybe one of the parents, for instance, has had depression or suffers from depression, and that person then maybe they've had a difficult childhood as well. Maybe they've been physically, emotionally, or also intimately or sexually abused. All of those make them predisposed, and then the precipitating factor could then be that they have a relationship breakdown, or that they have a stressful job that is unremitting, or that they have to relocate and emigrate, relocate from one place to the other, or that they have to emigrate, or that they develop a chronic physical illness, and that then begins that what tips them over the edge for them to develop that first depressive illness or a relapse. However, in addition to that, what then happens is that it's also what is called perpetuating factor, what is it that maintains the depressed state. So this person already has some things innate in them that makes them at risk. They then have an event that pushes them over, or a number of events that pushes them over, and then there's something that then precipitates the depressive illness itself in terms of pushing them over, and then there's something that continues to maintain it. So maintaining it could be even the personality, the way for somebody's personality. We all have our different personalities. There are some of us who are more critical of ourselves than others. We tend to be overcritical, tend to be pessimistic, oversensitive to comments and to adverse situations. And all of those with low self-esteem or low self-esteem, or a tendency to be anxious, all of those things are actually known to then be able to maintain a depressed depression. And the good thing about all this is that they can be addressed. The way we think can be addressed, the way we see situations can actually be addressed. It's possible to address those things and to address toxic or morbid patterns of thinking, and to actually begin to develop patterns of thinking in a different way. There's also some research showing that increasing age could actually put more people at risk. One of the things to consider in that case would be loneliness. The fact that loneliness, chronic physical illnesses, heart disease, for instance, heart disease, heart attacks, hypertension, all of diabetes, all of those things can actually associated with increased risk of depression. Some medication that are prescribed could actually are also associated for other conditions, might actually be associated with depressive illness. Use of substances, alcohol, and then prominently lack of confiding relationships. So if you are somebody who has a tendency to ruminate over things, to dwell over things, think about them over and over and over and over again, and you don't have people in your life that you trust, that you can confide in, that can also put you at risk that can also put people at risk of actually becoming depressed. And of course, we do know that women do get depressed as well. Soon after a baby is born, we don't know exactly what causes that, but a lot of things have been thought about, maybe to do with hormones, maybe to do with even the stress of bringing a child into the world and the changes that imposes on people's life, probably sleep disruption, all of the challenges of those may actually be associated. So what are the forms of depression? Because depression is not just one single thing. In the real sense of it, we have, so depression could be mild in terms of its, we can classify depression in terms of its severity. So is it mild, is it moderate, is it severe? Basically, the simple way to look at it is the number of symptoms that one has and the intensity, the way that the severity of those symptoms, the number of the symptoms, different symptoms, and the severity and the impact that it has on one's functioning is what determines whether it's a mild one, whether it's a moderate one, or it's a severe one. And that's important because the reason why it's important is because really the severity of the depression is what determines how it's treated. And I've also mentioned there's also a reference to psychotic depression over there. And the reason is because depression can actually be severe to the point in which people lose touch with reality. So in two ways, either that they begin to, and they could actually experience both, either that they begin to have experiences that are not in touch with reality in terms of hearing voices which are not there. So people are hearing voices when in actual sense there's no one talking. That's a possible. That's one of the things that happen when severe, and this is the most extreme and severe form of depression. Also, there could also be instances in which people begin to have beliefs that are not fixed in reality. For instance, somebody who is comfortable, an elderly person who is well retired and they've got a nest of eggs in the bank. They don't have any reason to worry. They think they're poor, they're about to go bankrupt, or they think their house is about to be repossessed, even though they've already paid for the property. Or people begin to even feel, some people begin to feel that they are emanating a particular smell, or that people are talking about them, or that their neighbors are plotting against them. All of those things could actually happen as a result of the very extreme forms of depression. The other way that you can look at depression is that, is this a first episode of depression? Is this single, when somebody has had a single episode? And I suppose the reason why I've put that on the slide is this, that a lot of people a lot of people have this false belief that depression is something that if you have it, then you have it for life. But that's not correct, because we do know that only one out of two people who have who come down with the first depressive episode would then go on in their lifetime to have a second episode. So that means that 1 out of 2 people would never have another episode. So they have a depressive episode, they are well taken care of, and they also understand themselves better. And as a result of that, they are actually able to prevent subsequent episodes. So I suppose the message there is that the fact that one has had a first depressive episode could actually be a warning sign to begin to develop more insights, to try and understand oneself better, to try and understand what has tipped one over, and then actively prevent another episode from taking place. And that's good news. The other thing we do know in terms of thinking about depression is that depression could also be part of a manic depressive illness. So depression is when it's very low, like I've described earlier, but mania, or to be manic, is when it's on the other side of the spectrum, where people are spending a lot of money, do not have a need to sleep, talking very fast, full of energy, coming up with ideas that are not really that are grandiose in terms of they're over the top, they are not really achievable, and also putting oneself at risk. Risk-taking behavior is some of the things that happen. Not sleeping at night. So depression can also be a part of that spectrum in which there's a depressive part of it, but there's also the part of it that is that is very high. But usually, the thing that we know is that sometimes the depression is single, it's just one pole, and then there are people who also have their depression in context of a manic depressive illness. Seasonal affective disorder has to do with, particularly in the colder climates of the world, where over the cold seasons, over the winter months, people actually become depressed, and they find that we do feel that it might be related to hours of sunlight and hours of exposure to sunlight. And one of the ways that that's treated is to actually use what's called the light box, where people would actually have exposure to light, which does not have any ultraviolet radiation, so it's not harmful to the body, for up to about an hour, 30 minutes to 1 hour every day during the winter months. And people do say that that can be very effective. And of course, I've talked about postnatal depression. So I think history is something that I particularly enjoy. I like looking at the history of psychiatry particularly. And some of these I've always known. Some of the figures that we are showing here now, some of the people who are featured on the slides, over my course of being a psychiatrist, I've known that they have in the past had problems, that there's records showing that they had problems with mental illness. For instance, Sir Winston Churchill, who was a very prominent prime minister in the United Kingdom, was actually was renowned to have suffered from depressive illnesses. In fact, people say that the term "the black dog," depression is usually colloquially in the UK, at least, is referred to as the black dog. That term actually came from Sir Winston Churchill. But the interesting thing is, despite the fact that it's well known in history that he suffered from mental illness, particularly depression, he was still one of the most remarkable prime ministers in the UK. And we do know that, particularly during the Second World War, his leadership of Britain was very particularly inspirational. So the thing to say is that if there are people who are here today who are listening to me and you've been diagnosed with depression, or you suffer from bouts of depression, the words I want to sell you hope tonight. That doesn't necessarily have to be something that's going to prevent you from fulfilling all your potentials, because all of the people on this slide, when Victoria, she also had a very noble reign. Was up until very recently the longest reigning monarch, up until the queen, the current queen. And Abraham Lincoln was another one. He was also very prominent. So all of these people, and for ministers who are on the call tonight, Charles Spurgeon, Prince of Preachers, who was also, he was described in many writings describe him as the most the most famous 19th century preacher. Yet he used to refer to spells of depression. In fact, he used to go away to France, where for warmer climates, with a view to treat his low mood. And all of these people are people that are not they are not strange to us. The current Pope has talked about the fact that he saw a psychoanalyst when he was in his 40s, and that he wanted, and that the reason why he lives in the place where he lives now and doesn't live alone in the Vatican Palace is because of he said for psychiatric reasons, because he needs to be in company of people. So it just tells us that really having the diagnosis of a depressive illness should not be a sentence that prevents people from achieving and fulfilling potential. So what are the things that somebody can do in terms of helping oneself if one is diagnosed with maybe the depressive illness? There's what is called bibliotherapy, and bibliotherapy is really about getting to know about the depression, about reading up about depression. And it's not just about reading up about depression, some of the things we are doing today, for instance, but also getting to know what are the things that I can do to help myself. And one of the most well-recommended sources to go for that is the website that is currently featured on the screen, www.livinglifetothefull.com. That's one of the most well-recommended one in the UK. And it's very easy to follow. It's also it's very rich content as well, and people can follow at their own pace. I've read that that's one of the most recommended ones. There's also the book by Dr. David Burns, which is this that I'm showing. And that's also a book. It's the New Mood Therapy. Dr. David Burns is one of the very first proponents of cognitive behavioral therapy, following on from Professor Aaron Beck. So they are the fathers and grandfathers of cognitive behavioral therapy, which is one of the more leading therapies for addressing depression. So that's that. What are the other things that one can do? The other thing that one can do that is very cheap and doesn't cost us anything is speaking up and requesting help. Sometimes people who are depressed find it a stigmatizing thing. They think it's a shameful thing because they feel they are going to be condemned. They feel they are going to be judged. But one of the most powerful things that anyone can do is to speak up, to find somebody that you can confide in and to actually let them know what life is like for you so that you can be supported to get the help that you need. Right. So that is really, really very crucial. It's important to do that. It's important to get help and to speak up. And in speaking up, so in fact, that breaking the silence and asking for help is one of the major ways that one can then begin to open up oneself for support and for help. The other thing, of course, is exercise. We do know that exercise is beneficial for mental well-being globally. And in terms of depression as well, do the exercise that works for you. If it's walking, if it's going to the gym, if it's aerobics, if it's dance aerobics, for instance. If you enjoy dancing and you enjoy music, then you can do dance aerobics. So in that case, you are killing two birds or three birds with one stone. You are improving your mental well-being. You are lifting the depression. You are releasing chemicals in your brain. Feel-good chemicals in your brain called the endorphins, and also you're also keeping fit. So that's also another way. It's something that you can do, structuring exercise, structuring your day, a little activity every day. The tendency when people are depressed is to want to not wake up out of bed, not to change out of your night clothes and just spend the whole day in bed, but mechanically bringing oneself out of bed and going through the motions initially would actually help to the point in which one can then get into the swing and into the flow of doing things in a different way. So scheduling activities, and for those who support those who are depressed, one of the things that they can do is to actually help those people to schedule activities and to help them to schedule activities and to actually help them to continue to engage in those activities. So the other thing, of course, is that we do know that alcohol is bad news for depression. Alcohol may lift mood for a very short while, but then it will then send the mood back into the abyss, into a very, very downward spiral. So in terms of alcohol, in terms of excessive caffeine intake, in terms of any street drug use, or even some prescribed drugs, some prescribed medication could actually be harmful in terms of recovery from abusing sedatives, for instance, can also become counterproductive. Ecotherapy is really about engaging with nature. That's something that I know I've had people say, and the reality is that it's very effective in terms of, and it depends on what you want to do. Some people enjoy walking in nature in terms of walking by the river. I particularly like going to riversides and to the sea, to beaches. All of those I find very relaxing. Some people, it's just actually working in the woods. For some people, it's actually bringing the outdoors into their indoor living area, planting plants. Or for some people, it's scents. There are particular aromas that you feel that would be very beneficial to your mood. So all of those things, music, is that we've talked about music already, and I'm also talking about music again. I always say that music can control atmospheres, and that's also scientifically proven, that actually there are certain activities, negative activities like violence, that are associated with certain negative type of music. So in the same way, positive type of music could be associated with mental well-being. So those are things, and there are things that can be done very easily without needing to consult with anyone. I also want to say at this point that for mild depression, which is what a lot of people experience, for mild depression, the way to, usually mild depression, there is no evidence showing that medication actually is effective for mild depression. What is this type of things, this type of self-help activities that have been known to actually be of benefit? Exercise. Diet is also very important. Eating the right things. Obviously, a balanced diet, high fiber, fruits and vegetables. All of those are very important. Fish oils. And spiritual support. And I also want to say at this point, because this is another thing that being a member of a Christian community, and also being a member of a Black ethnic minority community, I am aware that a lot of times we think that spiritual support and medical support is mutually exclusive. By that I mean, we think if you are doing spiritual support, then you can't mix it with medical support, and if you are doing medical support, you can't mix it with spiritual support. But what the evidence actually shows is that looking at depression in a global way and in a holistic manner is actually what helps to improve outcomes the most. So one should not negate or stop the other from taking place. We also do know that when people put themselves out to do something that doesn't necessarily benefit them in terms of giving to others, maybe in terms of charitable work, in terms of volunteering, in terms of contributing to the community, that has also been known to be associated with lifting of mood, and also to be actually known to be to have a particularly rewarding experience, and also associated with less depression and less anxiety. Taking up a new hobby, like learning a new language or learning a new skill, could also be it could also be helpful. And of course, the other thing is having a sense of gratitude, celebrating the little things that are working at the moment, even when one still feels that everything is not, all the ducks are not lined up yet. Because the reality is that there is always something to be grateful for. And there is lots of research in positive psychology actually showing that having a sense of gratitude, being intentional about looking for the things that one is grateful for, no matter how bleak life is, has been associated with less depressed mood, also better improvement and better outcomes, even when one is depressed. Right, so I'm just going to change slides. Okay, so like I said earlier, antidepressants are the second. When we've tried all of these things, usually when people go to their GP, antidepressants are not usually the first thing that people talk about, because all of these other things that I've talked about first can actually be helpful. And there are lots of people who get relief from depression from doing that. But then if the antidepressants are required, either because people are now beginning to find that they are having suicidal thoughts, or they are feeling that life is not worth living, or that they've actually become, they've started to lose touch with reality, then antidepressants might be indicated, or because they are no longer able to function in their daily life, antidepressants would then be a logical approach. the reality is that we currently don't know verbatim exactly to the letter how antidepressants work. However, we do know that they are effective for moderate and severe forms of depression. And the reality is that there's a spectrum of responses to antidepressants. Usually, the evidence doesn't show, the research doesn't show that it works in people with mild depression. It's not really recommended. However, for people who have a more severe form, it can be a lifesaver. A lot of people would swear by it that it's improved their outcomes. Sometimes people develop adverse effects in which it needs to be changed, but that's not to say that they will not be able to find one that works for them. It's been around since the 1950s. For instance, lithium is a natural occurring salt, just like the table salt, and it's also it has very strong antidepressant properties. It's been around since 1950. There are several other antidepressants broadly in about 5 different groups, and about 30 of them, and the number keeps growing. Antidepressants are also used for other things such as post-traumatic stress disorder, anxiety disorders, obsessive compulsive disorders. All of those, or even chronic pain. Some antidepressants are actually used for chronic pain. It's also instructive to know that for those who are prescribed antidepressants, that it could take up to 2 weeks for people to feel the effect. And sometimes that can interfere with people continuing to take medication because they think, oh, yeah, I've been taking it for 3 days. Antidepressants, unfortunately, are not like paracetamol, where one takes it and then one can feel the effect immediately. And sometimes people need to stay on antidepressants for several months. And the reason for that is, in fact, what the recommendation says, the National Institute of Clinical Excellence in the UK, which is the national body that gives guidance on every form of medical intervention, actually says that people should stay on antidepressants for 6 months after they have recovered. Not 6 months after they have started the treatment, but 6 months after they have recovered. So it's important to bear that in mind. And the reason for that is because that limits the risk of recurrence. Because the more depressive episodes that people have, the higher the risk that they're going to have another one. And after a third or fourth depressive episode, it's almost inevitable that there will be subsequent ones. So that's why it sounds very draconian and it sounds like one is doing an overkill by keeping somebody on medication for 6 months after they become well. But the reason is because we are trying as much as possible to prevent a second one. And we know that that actually has been known to be effective in doing that, in preventing a second episode. And what we want to do is to make sure that they said there is no second episode, because following the second episode, it then becomes the risk of subsequent episodes become higher. Right. So what we also know about antidepressants, like I've said earlier, it's not mandatory to take them. Particularly, what I mean by that is if it's a mild form of depression, it wouldn't be required. However, we've talked about the 5 different types. That's just all those acronyms they're just the areas of the brain or the chemicals of the brain that the antidepressants work on. And there are a lot of newer ones coming into the market now that don't just work on one single chemical, but work on a number of them. I want to say that antidepressants are not addictive because addiction is one in which you don't have an addiction until you cannot function without that substance. But also in addition to that, it's also that when that substance is taken away, one will need increasing quantity of that substance in order to be able to function. So somebody starts with maybe taking 2 cans of lager, and progressively they begin to increase, and they find that until they now reach 10 or 20, it doesn't give them the same effect that they were having from it before. So that's why antidepressants are not like that. There are people who have remained on the same dose of antidepressants for years and years, and or several months, and that has kept them well on that particular dose. However, sometimes it's not uncommon for people to have a withdrawal effect when they come off antidepressants. The withdrawal effect could be nausea, it could be vomiting, particularly when people come off of their own accord without being supported by their psychiatrists or by their doctors. That's why one of the things to bear in mind that is very crucial for one to take those decisions in conjunction and in support, with all the full support of one's clinician. Okay. So the other thing is that the other bad press that antidepressants has, which I want to address right now, is that a lot of people associate antidepressants with suicidal behavior. The first thing I want to say is that there has been increasing suicidal ideas. There's been some link between increasing suicidal ideas, not attempts, but ideas in young people who have been prescribed antidepressants. And very, very rarely would you prescribe young people antidepressants. There must be a very, very pressing need to do that. So the guide, but in adults, that's not a phenomenon. That's not something that we experience. But usually, as a precaution, when young adults, maybe people who are just in their older teenage years and also in their early 20s, are prescribed antidepressants, one of the things we do is that we in the very first few weeks, we keep an eye on things to make sure that we monitor them and that we are sure about what's happening, so that they can be well monitored should there be a situation in which any of those things develop. So that's that for, because many times people say, oh yes, it doesn't cause suicidal ideas. It doesn't. It's only in young people where it does that, and it hasn't been associated with suicidal acts. It's not. So that's something to also note. Okay, so. What else do we know about antidepressants? What are the fictions or the myths around that people, so some of the beliefs that are in our communities that are not actually accurate? I've talked about the one that they are not addictive. Some people also believe that, if somebody starts to take antidepressants, then that means that their condition will become worse in terms of they are never going to recover because they started antidepressants. That's also inaccurate, because we do know that if it's been rightly prescribed and it's been prescribed for those who need it, it's actually commonly associated with better outcomes. I've talked about the suicidal ones. The other thing that people erroneously believe is that as soon as you start antidepressants, then you are going to be on it for life. That's also not the case. There are people who have had one depressive episode. Like I said earlier, that 1 out of 2 people who suffer one depressive episode will never have any other one in their entire lifetime. And so that means that they will be on antidepressants. When it's 6 months after they've remained well, they will be taking off the antidepressants in a very cautious way, and they've never needed to go to take them again, either because they now have a better understanding of their stressors, they now have a better understanding of their own moods, they now have a better understanding of their relationships, they now have a better understanding of their own thinking patterns, and they're able to then manage those things in an effective way to help them to actually live an effective life and to stay well. And of course, we've addressed the fact that depressive illnesses are not a sign of mental weakness, and they are not a sign of spiritual weakness. And of course, many times, one of the things I say to patients when I prescribe antidepressants and they come in for a review is, I want to find out exactly when they're taking it, because there are antidepressants that are meant to be taken in the morning and there are the ones that are meant to be taken at night. If one takes the one that is meant to be taken in the morning at night, what's going to happen is that they are probably not going to sleep well because they've been taken at night when they are meant to be taken in the morning. And if one takes one that is meant to be taken in the morning, if one takes one that is meant to be taken at night in the morning, what's going to happen is that because it's meant to induce sleep and to help people sleep, then they're going to struggle to keep awake during the day because it's going to cause drowsiness. What else do we know about for want of a better word, let's say the flaws or the faults of antidepressants, basically that they have adverse effects. So the first thing is that commonly a lot of them are short duration. They don't last a long time, and they usually last from a few days to a few weeks. Usually a couple of weeks generally. The common ones are things like nausea, abdominal pain, diarrhea, constipation. Some people have talked about drowsiness. Some people find that it could increase their anxiety for a short while, for a short period after they start taking antidepressants. There can be a worsening of the anxiety, but that a lot of people also find that, like I said, does not last a long time. Sleep disturbance, it's important to take it at the right time. Headaches, dizziness, dry mouth, all of those. Talking about dry mouth, I'm just going to have a sip of water. Weight gain, some of them are known to cause weight gain, but the way to handle that is when those are prescribed, we will usually issue an alert along with it saying that there's a risk of weight gain. And usually the way to then deal with that would be to ensure to encourage those who are taking the antidepressants to be careful about their diets, and particularly also to engage in exercise. Appetite problems could be increased or decreased appetite. And sometimes people find that it also interferes with their sexual functions in terms of diminished interest or performance. All of those can be addressed because there are things that can be done in terms of either changing the antidepressants or adding something to it. Very commonly, it's usually that the antidepressant is changed. Okay. I can see there are a number of questions on there, but I will address those very shortly when we finish this. So what are the other interventions? We talked about self-help in terms of the things that people can do to help themselves. We've talked about antidepressants, but there are other things that also are prescribed or that as professionals we would advocate. So for instance, one of them is cognitive behavioral therapy, or actually talking therapy. It's not just one form of talking therapy. We've got, for instance, it's called cognitive behavioral therapy. It's really about somebody sits down with the person to be able to identify the toxic thinking patterns that they've developed over time, either from their childhood experiences or from the way they see the world, themselves, and others. And then this person who is a therapist helps them to identify those toxic, harmful thinking patterns, and then to begin to change that narrative. So that's what cognitive therapy is about, cognitive behavioral therapy. Interpersonal therapy is really about looking at the relationship you have with yourself and how it affects the relationship you have with others. And that can be from the experiences that one has had in the past as well, the important relationships that we've had in a life previously, and how that we carry that over into current relationships, and now that could actually cause friction, and how that could be counterproductive to our moods. There's also couples therapy. If, for instance, the relationship is in trouble, the marriage is in trouble, all of those can be done, because all of those can actually tip somebody over. I know domestic violence has been something, and domestic abuse has been very topical in our community in the last 4 weeks or so, and for right reasons. It's good that we are shedding the spotlight on those things and really having a zero tolerance, because there are people who need help, and we cannot keep quiet about those things, because obviously they are very, very actively linked to mental problems. Depression, anxiety is one of them, post-traumatic stress. So counseling is really it's a situation in which somebody who is a trained expert would usually create a safe, sensitive space for somebody to be listened to, and sometimes just to hear them, to get this off their chest. And in that process, actually, the person might be able to join their own dots themselves and to be able to make sense out of what's happening and to be able to find their own solutions. Psychodynamic psychotherapy is really about going back into childhood, going back into the experiences that one has had as a child or in early life, and how that might actually be playing out again and affecting how one is behaving currently, and how that's causing mental illness and causing sadness. So social interventions is really about any form of social intervention, from housing to finance. All of those things need to be looked at as well when there's depression, because many times it's not just one thing. Like I said, it's a combination of factors that actually tip people over and and causes that to happen. ECT is electroconvulsive therapy. I want to say very quickly that it's something that is not very commonly used. It's only used for very severe forms of depression when it's life-threatening, when it's the last resort in which maybe somebody's not eating and drinking, they are so depressed that one has to really very quickly bring them. And its electrical treatment is always very safely done. People will be given medication to make sure that when the electrical treatment is applied, and it's safe electricity to the temples, that they might have a fit, but it will be such that it's very well controlled and it's usually very safely done. In 23 years, I've not had about any casualty. Transmagnetic TMS is transmagnetic brain stimulation. Is about putting electrodes on the brain. They're like stickers that are put up like a hat that somebody wears, like a cap, for half an hour, 5 days a week, and they send electrical signals to the brain and help to correct. It's basically like rewiring the chemical systems. That has also been known to be effective only most usually in people who have a mild to moderate form of depression. Vagus nerve stimulation is also it's a similar thing, but usually the stimulation is in the neck, around one of the longest nerves in the body, and it's commonly used for movement disorders, particularly Parkinson's, but it's also been proven to be effective in depression. Deep brain stimulation is common. It's currently used in the UK for motor disorders and Parkinson's. I'm not aware that it's currently used for depression. Here. Right. So we're now beginning to round up. What are the resources that people can actually benefit from? This one, the llttf.com, is one that I said is one of the most commonly recommended in the UK, and it's a website that people just go onto. It's basically I call it like a mental health or cognitive behavioral therapy university, open university, because at one's fingertip, just by the click of the mouse, it's a plethora of information, and one can actually walk through. It's like a workbook that you can go through. This second one, screening, is a screening tool that anyone can go on the website and actually you can actually administer the test. You just click, you answer a few questions, and it actually it's a screening tool to let you know whether you need to actually speak to somebody. And so if there are people here today who are wondering, am I depressed or not? I think that's something that you can very easily avail yourself for. It's private. You don't need to. You can do it yourself. And if it then recommends that you see somebody, then it's good to do that. The Good Thinking website is one. It's a London. It's a London welfare well-being website, and it's got lots of resources on it as well. And I've particularly named it because it's also got faith-based resources. So if you're a Christian, for instance, you can go there, and there's actually resources that are mainly tailored to the needs of people with the Christian faith, people with other faiths, very different aspects where you can get what's tailored to your needs, to your spiritual needs. Every Mind Matters. That's one I'm very passionate about, and that I'm always very keen to recommend, because I was one of those who were the voice of. I was one of the voices and one of the advocates, or one of the proponents of Every Mind Matters. The last two campaigns that they've done, I've actively supported that in the community and also been a voice to promote that. It's 5 questions that you answer, and when you answer those 5 questions, it generates for you a tailor-made plan for your mental well-being. So it's really made to it's really so specific. You answer 5 questions, and it's going to generate for you a plan that is specifically for your mental well-being. And of course, there's Samaritans.org. Samaritans is really about sometimes when you just want to talk informally, you don't want to talk to a member of the family or a friend or somebody who is known. that would be a good one to do. And also, we've got a book by Dr. Richard Scott. Dr. Richard Scott is a general practitioner who practices in the southeast of Kent, in one of the coastal areas of Kent. And that book is written as a result of is becoming unwell with cancer. But the interesting thing is he's then gone and reviewed all that. He's actually done a very good job of looking at faith and well-being. So he's looked at all the different aspects, physical health, mental health, and he's actually gone into it's actually collated research that has to do with all this. So it's really a very good resource if you're interested in looking at really in-depth way in which looking at all the pieces of research. That's a good book to have, and it's not a very big book. I think it's over 100 pages. Calm Zone Net is also a place where people can chat about their mental well-being. And Men's Shared it's specifically for men's health. It's actually for men who might want to discuss their mental well-being. And of course, there's the NHS website, there's the Royal College of Psychiatrists website, there's also the American Psychiatric Association website, and also there's also the Mayo Clinic. All of those places where one can really find credible information. Because one of the things I encourage people to do is, if you are going to look for information, make sure you look for information from credible sources where you can be sure that you're getting the facts. So how do you support people who are, if you know people who are depressed, how do you support them? Time, giving people time is very crucial. Listening to them, creating time to listen to them, selling them hope. I'm hoping that today I'm really doing a good job of marketing hope, because one of the things I wanted to do today was, if there was anyone who was on this call who really needs hope, I'm hoping that I'm really being effective in selling you hope that this is a tunnel you get through, and that there is life at the end of that tunnel, and that there is a light at the end of that tunnel. And that's one of the things that we can do for people that we know, holding their hope for them when they can't hold their hope themselves, until the point where we can give back their hope to them when they're in a position to hold their hope for themselves. We can also encourage them to take care of their temples in terms of their physical well-being, in terms of making sure that they are eating well, and that might include nudging them, that might include doing the shopping for them. Also taking them seriously if they start talking about the fact that they don't want to be here any longer. Let's not think, oh, that's just a cry for help, or it's attention seeking. And then playing with them as a team member to help them to take their medication, to help them to attend the clinic appointments, to help them to do everything that they need to be doing their exercises, going on with their new hobbies, or making a commitment to continue with maybe starting a project or starting some sort of volunteering. And then taking time out to take care of yourself if you're a carer. One of the most profound things you can do in terms of taking care of other people when you're supporting people who have mental illness, depression, for instance, will be to make sure that you also care for yourself, because there's what is called carer fatigue. Carer fatigue is when the person who is caring for the person also becomes drained and flat out themselves. And that can cause resentment. It can prevent them from being effective in their role. So it's important to take time out as well, get respite from the caring role. And of course, the final thing is about making sure that you also get knowledge, being able to understand what those people are going through. A lot of this I have spoken about today, but there is quite a lot of research. Professor Koenig, I've spoken about him before. Is the one that's done, is the leading name internationally in terms of well-being, health, and faith. And one of the pieces of research that he did in 2001 actually shows that they looked at mental well-being in terms of the impact of faith, and they looked at lots of studies looking at a lot of research that had been done, and they found out that 80% of them actually showed that a religious affiliation and having a spiritual having faith and being spiritual was actually linked to had a positive effect on mental well-being, and that less than 10% showed a negative effect. So that's really quite notable. And they found out that faith was positively correlated to well-being, to illness prevention, and to ability to be able to cope with continuing distress and disability. So, and what are the next steps? Just to say that these are part of the things that Psychiatry offers. Particularly, we do run a YouTube channel. We do have a WhatsApp group as well. We do monthly meetings like this. And currently, we are also beginning to do one-to-one support, to offer one-to-one support. And so in May, we are going to be looking at alcohol and substance dependence, the substance misuse. That's something I'm really looking forward to. I wouldn't be doing that. I'm going to get a substance misuse expert who is very, very renowned and very experienced in this field to do it. And so I invite you to please come along to that one in May, particularly because that's an area that I hear it a lot, and I speak to a lot of parents who are having those challenges in terms of supporting people in their community or supporting their children. So please, even if you don't have somebody directly that you directly know, it's important to come and find, gain knowledge. And personality, making yours work for you. That's what I'm looking forward to as well, because really that's something we can learn about. That's really something. Getting to know myself was one of the most pivotal breakthroughs I had in my entire life. Getting to know what works for me and who I am, and accepting that that's the way that this is who I am. This is the way God wired me, and this is what works best for me. And if you, I do encourage us to please make some noise on social media. If this has been of benefit to you, the hashtag is TripartCare. Please, let's spread the word on LinkedIn. Let's spread the word on Facebook. Let's spread the word on Twitter, wherever you are, wherever you have a social media presence. And the other thing I wanted to say was that all of these trainings and all of these are actually being concurrently compiled into a training manual or into a training package for churches, where we can actually deliver this training to your congregation in an effective way. It's very important that all our workers, all our leaders are well trained to be able to identify these things and to be able to know what to do. Okay, so those are the updates. Please take a photo of that if you need to. And this video is going to be edited and then it's going to be uploaded onto YouTube anyway. And that's the WhatsApp group. So you can actually also take a photo of that, and that's the QR code. If you take a photo of that, it will actually lead you to the website, to the group. Okay, so, and those are my contact details, the email, the YouTube channel, Facebook, and LinkedIn, and Instagram. And I can see that there are quite, so that's it. And I'm just going to look at the chat, and or if there is anyone who's put any what do you call it, any questions on the chat, please let know. Right, okay. So somebody's raised their hand. I'm just going to see who that is. I'm going to stop sharing so I can see people, and I can see, okay, somebody's raised their hand. Who's that? Who's raised their hand? Okay, right, Dr. Ho. So please, the floor is yours. Dr. O, please unmute yourself and go for it. Please unmute, Doctor. Okay.
Okay, now I'm able to. Thank you so much, and good afternoon, everyone, from my end. I just want to thank you for this brilliant presentation, much needed in our communities at this present time, and before and now, actually. Thank you for your boldness to share in our community, because mental health is something that it's not readily accepted, and care is not given in this area. I wanted to just add to what you've said, that treatment is now much easier than it used to be in psychiatry, because we have tools like what we call in the US gene site testing, that utilizes saliva from your mouth to use your DNA to see what medications will work best for you, so that we are not groping in the dark when you get treated. And your medication can be tailored to you. If after everything that you have said does not work and medication is needed, then somebody can know that this medication is actually perfect for them for the duration they will need treatment, or forever. Thank you.
Yeah, thank you very much for that contribution, Doctor. Interestingly, only today, I was attending a lecture on psychogenomics. So we are not as advanced yet in the UK, but we are right behind you on your heels in terms of really coming to that level. Interestingly, I was just at a meeting today where that was being discussed in terms of really UK. There's some study going on currently where we are recruiting into those type of studies. So that's also something encouraging, that the future looks very bright in terms of treatment options. Thank you so much for that, Dr. O. Dr. O runs a, as you could have worked out that she's logged in from America, and she runs a Medical Mondays with Dr. Ho as well. Which is a program like this where she discusses issues relating to well-being across board. Thank you for all you do as well. Okay. I'm just scanning to see, and if there are any questions, please, by all means, please just indicate by raising your hand, and then we'll come to you. Meanwhile, I'm also scanning to see. Okay, somebody says spirituality is the key to mental health as long as it's right source or link. Very happy that's spiritual. Okay. Very happy that's spiritual. I think that's something to do with the fact that we are looking at mental illness and interventions in a wholesome way, which yes, I think I agree with that. It's important that everything is looked at in a robust way rather than being myopic, because that's what the evidence shows is effective anyway. Right, okay. Okay, yes, the book that I recommended was Feeling Good, the New Mood Therapy, Feeling Good, the New Mood Therapy by Dr. David Burns. It's written in lay language, and it's a good book. Particularly if somebody's experiencing depression, there are several practical exercises there that one can engage in, and one can use them. Okay, yes, so that's the name of the book, Feeling Good. And one of the course can please write that on the screen again. Feeling Good, the New Mood Therapy, Feeling Good by Dr. David Burns. Okay, gratitudes, that's, okay, thank you. Somebody said very educational. Okay. Great to be here, thank you. Okay, excellent presentation. Okay. Right, okay. So okay, right, can we have, okay. Right, there's a question here. Can we have examples of thinking patterns that can lead to suicidal thoughts or depression? Yes, so yes, that's true. So that particular question, it's a whole it's a whole, what do you call it, on its own. It's a whole 90 minutes presentation on its own. I'll recommend two things. One of them is that if you please go on the Tripart Care website, there is a title called Toxic Thinking. We did a full presentation with what do you call it, with exercises on that particular one. It's called Toxic Thinking. So that's one. But a typical example is what is called maybe I'll say maximization, in which so somebody the easiest one is catastrophizing. Catastrophizing is basically when one overestimates the risk of a situation. So we move into a new area. It's one of the safest areas in the neighborhood, and just because of one's thinking pattern, maybe because in the past you've been burgled, or in the past you've lived in unsafe neighborhoods, you just have this morbid fear that you're going to be burgled. And even though the statistics shows that it's a very safe area, they've never had a burglary there, but you're always worrying when you go to work. You're always when you go to work, you're always worrying that maybe I'm going to get a call, or when I come back home. So that's overestimating the tendency that something is going to happen, a bad event is going to happen. So catastrophizing is one of them. One of them is also overgeneralization. When based on a single negative incident, you then assume that you are going to have negative outcomes in the general situation. And each of the about 16 different patterns that are involved that have been named. But also in addition to that, some of us, in terms of, it's not just about generalization or thinking patterns. For some people, it's also the way we think about ourselves. Some people, either because they've been brought up in a very harsh way, or maybe they had harsh parenting or harsh schooling, boarding school and all that. Sometimes that has actually been imbibed to the point in which people are overcritical of themselves, and they also don't think good of themselves. They put themselves down constantly, and they are their worst critic. That is also associated with depressive illness. Low self-esteem, poor self-esteem has also been associated with depression. I can see Frank has raised his hand. Please go for it, Frank. Sweetie, I think you need to.
Oh, thank you very much. Thank you, Dr. Idalia Jai. That was a fantastic presentation. It's a pleasure. I look forward to seeing you in person again.
Look forward to the same as well. Thank you.
That was just so tremendous. Bless you. A quick question. You mentioned about manual for churches. You know, you can see from my background, it's South African, but with an English background. And in England, it's also not proper to talk about your mental health. So there's a real need in the churches that I've been involved as well, because most English people would say, "How are you?" "No, I'm fine," which just stands for feeling inadequate, needing encouragement.
that's I never had it that way.
So thank you for that encouragement. That is really great, and I really look forward to hearing or finding out when those manuals will be available, because that's an incredible resource for pastoral leaders as well. Thank you so much.
Thank you. Thank you for that comment. Yeah, I think it's a valid point you've raised in terms of really the fact that we all need as a community to change our attitude towards receiving the response to how are you. Because the reality is that sometimes when you actually ask people how they are, or when people ask you how you are, they really don't want an answer. Really, in the real sense of it, if you do actually say how you are, they feel lost. You can almost tell that they were not prepared for a genuine answer. So I think part of this events hopefully will equip us on how to really deal with those situations. So thank you very much. It's a valid point. Right. Okay. Any other questions? Any other questions? Right, okay, good. Okay. Let's just see. I'm just going to go through the comments again as we round up. Let's just see what's happening here. Right, okay. So somebody wants to find out about the journey to becoming a psychiatrist. Yeah, I'm impressed. Thank you for asking. You've made my evening. The medical students who passed through my placement know that I'm always an over-enthusiastic psychiatrist who's always trying to recruit people. So thank you for asking. The first thing is that you need to get into medical school wherever. So if it's in the UK, you need to go through your A-levels, or as a mature student, either as a graduate or as an undergrad, either as a graduate or as a college student, apply to medical school. And then when you get into medical school, you can then specialize in psychiatry. So medical school is 4 to 6 years, depending on when you enter or at what stage you enter. And specialist training in psychiatry in UK, there's the FY 2 years of foundation year as a doctor, and then 3 years of core training, and then at least 3 years of specialization. So about 7 years after. Yes, thank you for asking. And you can contact me if you need further support. There's quite a lot of support that we can render to you if you're already in medical school. And if you're not in medical school yet, there is also a lot of support. One of the things I didn't mention is that I also do oversee and run an organization, Mentor into Medicine, where we support people from disadvantaged backgrounds to get into medical school. So please give me an email or just get in touch and we'll point you in the right direction. Okay, right. So yeah, there's another question about how an individual can develop mental illness. I think that's something that we've talked about earlier as well, that it's really, there are several risk factors, and it's only not just one thing. It's not usually one thing. It's usually a number of things coming together that then tips the person over. So thank you everyone for being with us tonight, and for, I'm really impressed that we still, most people have waited till the very end. And thank you for coming tonight. And we'll be uploading the video as soon as it's edited onto the YouTube channel. And I look forward to seeing you next time. Once again, God bless you. Bye.